Hi, welcome to the Orthomind Podcast, powered by our team here at FARIL. I'm Nate.
I'm George.
I'm Sion.
Today, we're honored to be joined by Dr. Kiran Agarwal-Harding, an orthopedic trauma surgeon at Beth Israel Deaconess Medical Center, assistant professor of orthopedic surgery at Harvard Medical School, founder and director of the Harvard Global Orthopaedics Collaborative, and founder of SONA Global, a nonprofit developing affordable orthopedic devices for resource-limited settings around the world. Dr. Agarwal-Harding, thank you so much for taking your time to join us here.
Thank you. Pleasure to be here.
Okay, to start, Dr. Agarwal-Harding, you framed the global surgical access crisis in a way that's hard to forget. 5 billion people worldwide lack access to safe, timely surgery when they need it. And you've been specific about what that gap actually looks like on the ground. A femoral shaft fracture in Boston means surgery within 24 hours and the ability to walk the next day. The same injury in Malawi might mean weeks in traction without anesthesia, along with consequences that follow a patient for the rest of their life. For someone who has never seen that disparity up close, how do you help them truly understand the scale and the urgency of it?
Great question. Jumping right into it. Well, the statistic that we quote a lot in our papers, and I think that's very kind of alarming for folks who aren't familiar with the field of orthopedics or trauma, is that globally 5 million people die every year from trauma alone. And that's more people than die from tuberculosis, malaria, and HIV combined. And that's deaths. If we also think about non-fatal injuries, for every one person who dies, 10 to 30 times as many people are affected with non-fatal injuries that can be, severely disabling. So I think that's the scope. That's the size of the problem that we have to deal with. The reality is that 90% of people globally don't have access to the essential care that they need to take care of these injuries. So that's, I think, where we find a huge need worthy of addressing. That's unfortunately not really talked about.
Thank you. And was there a specific moment, maybe a case, a trip, or something else that you witnessed where the weight of this problem really landed on you for you personally?
So many. I think if any of you have the interest and are interested in coming and joining for our trips to resource limited settings or working with our partners there, you'll have the experience of going into a busy orthopedic trauma ward and seeing just the number of patients who are waiting for surgery in resource limited settings. It's quite dramatic. The reality is that without access to essential surgery, many patients with these injuries that here would get care immediately just wait. They wait and wait and wait for surgery that sometimes will never come. So we did one study, for example, in Malawi, where we specifically were interviewing patients who had femoral shaft fractures, trying to understand, how they navigate the health system, experience care before arriving at a central hospital where definitive treatment is available. At the time that we performed the study, the standard of care in Malawi was still skeletal traction, which is a non-operative treatment for femoral shaft fractures. Here, if you get a femoral shaft fracture, you guys know you would get an intramedullary nail probably within 48 hours, and be able to put full weight on it and walk the next day. In Malawi, even today, many, many patients receive skeletal traction because of lack of surgical capacity. So that means patients sit in, with a pin going across their tibia, weights hung at the end of the bed, pulling the leg out to length. And they sit like that for weeks, sometimes months. And there's a high chance of malrotation, shortening, non-union, knee stiffness. So someone who was a motorcycle taxi driver and broke their leg doing that, very difficult to imagine them being able to go back to work to feed their families. And during the course of their hospitalization, their family is, out of luck, right? Who's going to support the kids' education? Who's going to feed them? Who's going to house them, right? When the main breadwinner is hospitalized. So the patient that I'm sort of referring to vaguely here is someone that we really interviewed. Motorcycle taxi driver in Lilongwe, was in a car accident, struck by a car on his motorcycle while working, femoral shaft fracture, admitted to the hospital, put into skin traction, sitting like that for weeks. At the time we spoke to him, he was there for 9 weeks, still had a totally mobile fracture, most likely not going to heal at that point. His wife had come from the village to care for him because there are so few nurses on the wards that they require guardians, their patients' family members to come and feed them, bathe them, take care of them. And while his wife was there, the kids were in the village. Asked him, where are your kids? Who's taking care of them? Didn't know. Community hopefully gathering to support him. right? Who's supporting the money for transportation to and from the village? Didn't know. So I think that you see, obviously, there's a huge social impact, right? Obviously, there's a physical impact of having a femoral shaft fracture, the pain and suffering and being hospitalized and feeling very much like you're in purgatory, stuck in a hospital with no end in sight, you know. But then the other side, it doesn't just affect the patient, it affects the entire family, the entire community, right? And if you add that up to the millions of people who are affected by this, it's a huge economic detriment, right? A huge economic impact to the world and to some of the poorest countries where this care is not available. So billions of dollars probably are lost in productivity due to musculoskeletal injuries. So yeah, I think it's a great question because you know you want to anchor your commitment to something like global health in the personal, right? In the personal experience, the real individual patients that you meet. But when you think about those individual patients and you think about the scope of how many patients are affected, it really shakes you. And I think that's what inspired me to do this kind of work. I mean, my career in global orthopedics began when I was in medical school, and it was after the earthquake in Haiti that happened in 2010. So I went to Haiti in 2012 between my third and fourth year of medical school. And there were still patients on the wards with injuries that had happened during the earthquake 2 years earlier and had still not received the care that they needed. And the health system was just shattered by the earthquake, right? There were not enough orthopedic surgeons, not enough resources, not enough hospitals, right? Hundreds of thousands of people were affected in Haiti. And I think that's what really shook me. You go to a place and you realize how desperately needed these skills are. So I'm assuming that all you guys are thinking about becoming orthopedic surgeons or already are in training at various stages. You know, it's incredibly valuable, the skills that you guys are learning, and you'll find that, especially if you go to resource limited settings where it's not something that you can take for granted.
Thank you.
Yeah, thank you for that. You've described HGOC's research mission in a compelling way, explaining that research in a global health acts like journalism, painting a picture of what's actually happening on the ground, identifying the problems that need solving, and building the evidence-based to advocate for funding and real change. Could you walk us through how that philosophy shaped the way you built HGOC and what a research collaborative in global orthopedics actually looks like in practice?
Yeah, thanks.
Yeah.
Nice question. Well, I think that our philosophy of research has been really shaped by our partners. I tell all of the folks who work with me, all of the trainees that I work with, that our job is to identify local champions and do everything we can to support them, basically. Everything within our capacity. That's our role. So whether it's putting on educational conferences where we give platforms to folks to share their experience and their expertise with a wider audience and amplify their voice, or it's creating research projects that in many ways tell a story that they already know, right? But tell it in a way that's compelling that people can understand it and maybe perhaps act on it, right? Mm-hmm. So an example, I was with my mentor and dear friend Leonard Banza. He's an orthopedic surgeon in Lilongwe in Malawi. I've known him since I first started going to Malawi in 2016. But recently we were in a rural district hospital and he does these amazing programs where he goes out and visits rural health centers where the health navigators, these are clinical staff who help navigate between the rural health centers and the district hospitals. They had gathered patients who needed musculoskeletal attention, and his focus in these trips is mainly children. And so we go to these rural health centers and we run these clinics. And at one of these clinics, there were many, many patients with chronic osteomyelitis. Do you guys know what that is? Yeah. So chronic, well, of course you do for diabetes, right? For foot and ankle. But in children, it's oftentimes an acute hematogenous infection. So, you know, playing and tripping and falling and getting little cuts and bruises happens to kids all the time. It's very, very common. Here, it's diagnosed almost immediately, right? MRI is sometimes helpful to identify, you know, whether there's an infection in the bone. They can get good antibiotics. They can get surgery to decompress an abscess if they need it. And it doesn't normally progress to chronic osteomyelitis. Chronic osteomyelitis, generally speaking, is thought of as a disease of neglect. Okay. So we were in this rural health center and we saw many, many children with chronic osteomyelitis. And one child was 12 years old and his femur was bent at a 90-degree angle because he developed a pathologic fracture with a huge sequestrum, like a big infected piece of bone inside a now healed 90-degree femur. And as you can imagine, he couldn't walk, right? And came, quote unquote, walking into the clinic like that with his father. And you know, we had driven to this rural health center that same day from the capital city. So it's not like it was days and days journey for us. For them, it was an insurmountable distance, right? There's no way that they could have made it to the central hospital to get care. So Leonard going there, finding, you know, the kid in that clinic, taking him to a rural district hospital where we then decompress and remove the sequestrum and, you know, began the journey. This kid's going to be on a long journey of care. We did the case, and then that night we sat down and talked about it, you know, over dinner. You know, I asked, like, Leonard, how did this happen? You know, how did kids get this way? You know, how do they, you know, end up with such a horrible, I mean, training pus, 90-degree femur, 12 years old. It's not, you know, I mean, it was really difficult for me to imagine, like, how all these factors could coalesce to create this kind of situation for this kid. And it's not a single kid. It's many, many kids have this, right? That was one of like 4 or 5 cases we did that day with very similar kind of problem. And so, you know, Leonard had a bunch of theories. When they present to a rural health center, nobody knows what chronic osteomyelitis is or even acute osteo. So they think it's malaria because they come in with fevers. Or they ask the parents, it's like, did the kid fall? And the parents are super deferential to the authority of a healthcare provider. Yes, the kid fell. Okay, paracetamol, give just Tylenol, right? It's probably just a sprain. And then they come back with a draining wound. And then they see someone who can do surgery and they don't think to decompress the bone. There's no imaging, so they can't like evaluate the bone. They can't really interpret the x-ray well enough to see if it's chronic osteo or not. They may do a small debridement, just releasing pus from under the skin, but not really drilling and removing it from inside the bone. Maybe they don't have the resources to do that. All these theories, right? These are just theories. We have no idea if that's true. Any of this is true. It's just his experience, but I would trust his experience, but it's quote unquote level 5, right? That's like level 5 experience. So we got together as a group. This is like what HGOC does. We took Leonard's feedback, talked to him more about it. We started to dive into the literature. We found that there's not a lot of stuff published out there about chronic osteomyelitis. So the first step was, let's just try to understand the scope of this. Let's see, you know, what the experiences of these patients are. Is it true that they got diagnosed with malaria first? You know, do they say that? Did they really go to a surgeon who didn't perform a proper debridement? Is that real? And so we started to interview patients. And as we started to interview patients in Malawi, our colleagues within our network at HGOC in Ethiopia and in Nigeria contacted us and said, hey, this project's super relevant to the experience we have too. And it's maybe a little bit different. In Ethiopia, they have traditional bone setters, which adds a whole other dimension to this because the traditional bone setters, these are like traditional healers, non-physicians, you know, not within a formal care pathway, who take care of patients in the rural setting primarily. And they're the first point of call for most patients because of accessibility and cost, right? And then in Nigeria, there's like a really complex system of private and public care that's not fully regulated and very convoluted. And so these 3 different health settings, we wanted to explore with the same question, like what happens to a kid when, like what has happened to a kid who has chronic osteo, chronic, delayed, severe, neglected osteomyelitis? What happened to get to that stage? And I think the lessons we learned were really interesting in that there were, you know, similarities between all these different settings, but also differences. So that's, I think, like, that's a great, in my mind, a great example of how we are sort of like investigative journalists, right? Like this question came up, it was grounded in a specific case, the experience of a single surgeon. And that certain, you know, Leonard's impression in many ways was right, what he was saying. Like a lot of these kids were diagnosed with malaria first. A lot of these kids didn't get the right antibiotics. A lot of these kids were referred in these convoluted pathways that never really ended up in a place where they could get the proper care they needed. But I think formally telling that story adds value, you know, to the conversation. And now, like, we can start building more partnerships, building more research projects, start bringing in more grant funding to help support, you know, making care better for these kids. So I think that's where the philosophy came from. It was really people like Leonard who have guided us through their clinical experience.
Thank you.
Thank you. SONA Global was built around a specific insight. The devices that surgeons in high-income countries take for granted are often completely out of reach in lower and middle-income settings. Not because the technology is complicated, but because of the cost. Your team brought the cost of open fracture stabilization to less than 1% on the industry standard. How did you go from identifying that gap to putting a working device in a surgeon's hand in countries like Malawi and Rwanda?
Thank you. Yeah, I mean, first of all, I should clarify that these are still investigational devices. So our low-cost external fixator called AFIX is now in clinical trials in Sri Lanka and soon in Rwanda. We now have full approvals there, and so we should begin there soon. And then our negative pressure wound therapy device, Vitara. It's actually not just for negative pressure wound therapy. We've also discovered it works very well for uterine suction tamponade. I can talk more about that. But it's currently being clinically trialed for uterine suction tamponade in Botswana. And we have clinical trials for wound care and uterine suction tamponade about to launch in Sri Lanka and Rwanda as well. So I think, honestly, I have to attribute both of the devices to our network again. It has to do with the colleagues we work with. So the story of Vitara, our negative pressure device, goes back to a conference that we ran in Haiti back in 2018. That was the last in-person conference that we ran in Port-au-Prince before the political climate in Haiti made it impossible to do this in person. And during that conference, Christina Desjons, who's now a fully qualified orthopedic surgeon, but at the time she was a resident, she came to the conference with an aquarium pump that she had glued together and drilled holes into and added different specifications to make it function like a suction pump instead of like a bubbler. And she'd used saran wrap and gauze or like even the foam that you take out of a sofa that she'd sterilized to create like a negative pressure wound therapy dressing for patients in Haiti. And this was all kind of learned out of necessity after the earthquake, where so many patients had neglected compartment syndromes and chronic wounds and things like that. And of course, not to mention the huge burden of open fractures from road traffic collisions as well as gunshots. So she showed this to us and we were fascinated by it. We thought this was such a great idea. And so we took this back to Boston, kept thinking about it and worked on some refinements and new versions of this device. And that generated our first prototype, Vitara 1.0. The original idea of this was to make it totally open source. So if you look on YouTube, you'll find a video of me in my apartment as a fellow in New York making a Vitara device and teaching people how to make it, right? And so that was the idea. Anybody can make a Vitara. This is how you make it. But you realize that like busy trauma surgeons don't have time to make these devices. And the other thing I noticed is like when people would make them and send them to me, they wouldn't work. It does take a little bit of like a learning curve to learn how to make it so that it works properly. And we developed like a whole kind of protocol for testing it so that we can make sure that it was like working optimally. We took the device and also tested it in a whole bunch of other parameters to make sure that it was safe and effective in the laboratory. But that really sort of changed my thinking. So we shifted, like thanks to some of my buddies from back in the day, I went to Stanford for undergrad, and one of my best friends from our bioengineering degree, his name's Andrew Deegan, helped me co-found SONA Global. He was like, why are you making these in your kitchen by yourself? Like, we should just manufacture them. We should properly manufacture them. So we found manufacturers, we optimized the whole system, and we started manufacturing Vitara. That device we tested in the laboratory, then we started a clinical trial in Cameroon. And that clinical trial in Cameroon was supported in part, like at least intellectually supported very much so by Christina Desjons, who was helping Henry and Dasi sort of like think about how these could be used, receiving feedback on it. So that clinical trial went great. And then after that, we've, been able to get Vitara out to, hundreds of different people around the world. Ukraine, Haiti, Armenia, Venezuela, most recently. A bunch of pumps got to Venezuela. But, as we refined it, we learned a lot. What we were doing was great from an academic perspective. I think we significantly improved the lives of some patients who, certainly in Cameroon, 80% amputation prevention, right? We saved 80% of limbs due to the use of Vitara in these like complex mangled injuries. So the next step was, how do we operationalize this so it can reach more people, right? So that's when Andrew and my other co-founder Ravi, we started refining Vitara more, and we have an incredible team. Shout out to Jerry Zhang and Yashin Kuo and like so many people in my team at Sona, Ali Reza and Kabe. In our laboratory, we further refined the device to something that could be like mass manufacturable, and that's where we are right now. So the device now can be manufactured for very, very low cost. We've tested in the laboratory. We're starting this clinical trial in Botswana. And I think like as we did this through all the academic connections, the uterine suction tamponade was kind of an exciting new way of thinking about the device. Turns out that the pressure you use for negative pressure wound therapy is the exact same pressure that you use for uterine suction tamponade. So after delivery of a baby, if a mother is bleeding excessively, the first line is to give medications and to massage the uterus to cause it to constrict. But if that doesn't work, the second line therapy in most low resource settings is to insert a balloon to inflate the uterus, which sort of does the opposite. You want the uterus to constrict, but if it doesn't work, then you mechanically tamponade it by inflating it. And when you deflate it, you don't know if it's going to start bleeding again. It causes a lot of pain. It stops it blocks the urethra, so women can get urinary tract infections. The standard of care in the United States today is uterine suction tamponade. And this was developed by a proprietary, very, very expensive catheter that relies on wall suction. And so as we sort of started exploring the space, all these colleagues of ours who work in low resource settings said, you don't need the proprietary fancy catheter. You can use a simple Foley catheter, chest tube, gastric tube. But the problem is we don't have suction source. We don't have wall suction in a lot of these like rural district hospitals where most of these women, unfortunately, are dying. So why can't Vitara be used for that? So that's, I think, a very exciting new way that the device is being implemented. And so we're exploring that now, how to get it out there into the world. The other side of all this, though, is you develop the devices, but a single device represents a point in a continuum of care for a patient, right? Just like I described for uterine suction tamponade, there's the uterotonic medications, the fundal massage, then there's the uterine suction tamponade. And if that fails, you need to know when it's failed, and then you need to know how to do a hysterectomy to save a woman's life, right? That's a whole continuum of care, right? And in our organization, we emphasize that that's our goal, not to create a single product for a single person, right? It's the mission of creating equitable care for everybody. And so same thing with negative pressure wound therapy. Our other device is a low-cost external fixator, which we similarly tested in the lab, and it works just as well as the industry standard device, and we're clinically trialing now with excellent results. But what we do is we teach open fracture care with the essential principles that can, apply to these two devices, when to apply negative pressure, when to apply an external fixator, how to do that. But which patient needs it? Then what do you do once you've applied it, right? You get a patient who comes in with a horrible injury, debride the wound, put an X-fix, put a negative pressure wound therapy. They're not cured yet, right? They still need to get all the way to the point where you've reconstructed their limb. So how do you get there? We need to bring in plastic surgery to understand how to do flaps. We need to understand how to deal with bone defects using Ilizarov or Taylor spatial frames, right? Bone transport, masquelet technique, right? IM nailing, plating, right? It's all part of the continuum. So training a surgeon can't just be little point moments. It needs to be comprehensive. And so I think the education program we've developed, plus the devices we've developed, these are constantly feeding each other, right? The education helps us really hear the voices of providers who are taking care of patients in low resource settings, and then try to develop solutions that meet those needs. And then once we develop those solutions, implement them in a way that's part of a care continuum. So I hope that answers the question.
Oh, really interesting. Thank you. And you offer SONA devices on a donate what you can basis, including for free in the lowest source settings. How do you sustain that model, and where do you see it going?
Good question. Good question, Sion. I wish I had a crystal ball and I could know whether our system is going to work. Because honestly, our goal is sustainability. And without sustainability, we cannot make an impact. There have been many organizations that have just donated, right? And they've done incredible work. But as I'm sure you guys can imagine, donation is a tough game to be in, right? There is, of course, the limitation with donation eventually drying up when the generous donor moves on, right? Or for whatever reason, priorities change and the donation vanishes. But there's also, I think, historically, like a lot of complication associated with donation of implants, donation of anything really. The older kind of format, and I shouldn't call it older because in many ways it still occurs today. The mission driven, I'm a surgeon, I'm donating my time, I'm coming and doing surgery for a week and then I'm leaving. I'm showing up and here's all the garbage from my hospital that they don't want. Do you guys want this? That creates, first of all, like a very complex relationship with local staff. Very complex dynamics also with the patients. And creates a kind of dependency, but also a lack of quality for patients, right? So I've been to hospitals where the courtyard in front of the clinic is a graveyard of dead devices, like devices that have been donated and being found useless because they didn't have one part that should have gone with it to make it a full thing. And so it's just been discarded, right? And so that's not what we want, right? Right now, in most of the hospitals I visited, in Malawi, Rwanda, Ethiopia, rural Kenya, the external fixator, which is a mainstay of essential trauma care, right? Like whether you're rich or poor, if you have an open fracture on the highway and you come to a district hospital, any hospital that provides surgical or trauma care, you need to get an external fixator, whether you can pay for it or not, right? So the external fixator that's on the shelf in hospitals that have it, in many cases is donated. And that donation is usually in the suitcase of some well-meaning surgeon. And that's good, right? It serves some purpose. I'm not going to belittle that. But what happens when you use up that X-Fix? Who's going to replenish it, right? And what happens if you're missing a component to it, like the one screwdriver or the one wrench that opens up that one X-Fix clamp, right? So there's also no quality to make sure that, is that used? Has it been used too many times? Is it going to hold right? So I think that regardless of where you're born or what your finances are, you deserve to have essential surgery, right? And regardless of where you work as a surgeon, you deserve to have tools at your disposal that provide essential surgical care. And that's, I think, the philosophy behind what we're trying to do with SONA. We want to create something that provides the same standard of care as what we have here in Boston, can provide negative pressure wound therapy with the same outcomes as a fancy device, can provide external fixation with same mechanical function, same technique, and same outcomes as what we use here, but for a fraction of the cost, right? And that system will require some form of sale, like a sustainable system, right? Some people buy it, some people get it as donation, perhaps. It's a sort of pay what you can model. That's what we're thinking of. And that requires partnering with folks outside of just like me as an orthopedic surgeon, right? Like I need to build a team with whom I can work that have the insight from the business side, from the philanthropy side, from the venture side, right? To really build a system that can effectively deliver that kind of care. And it's not easy. It's not easy for me. It's been a challenge because I think that the way that innovation works generally is it's all about an exit. Who's going to buy my company someday? Who's going to take my nice screw that I've invented, that I've confirmed is great and works awesome and so nice to put it in? Who's going to take that screw and buy it and make it part of like the big five, the big five companies in orthopedics? And that's my exit, right? What we're trying to do doesn't follow that model. What we're trying to do is create something that's available for the poorest people. It's almost like we're trying to create a generic drug compared to an industry, leading innovation, right? And I think that kind of disruptive paradigm shift is sort of out of the box for most people to think about, right? Because and from a financing perspective, it's very challenging to imagine, right? So SONA Global is a nonprofit. Everything we've done to date has been through donation. People have donated their time, people have donated money, people have donated their skills, and that's gotten us to where we are today. But the next step, like how do we take a device that can be generally available to all and make sure that it's actually on the shelf. It's really hard when poor people can't pay anything, right? Like in Malawi, health expenditure per capita is $30 per person per year for healthcare, right? That's really, really low. Like, how can we, like, even if we were to make an external fixator, $5 a clamp, you need 6 of them to make a construct, right? That's it. That's a whole cost. That's not including the surgery. That's not including the pins or the rods. That's not including the time of the surgeon, right? So something needs to give. Some way for paying for the care for the poor needs to be imagined. There will always be poor people who deserve care from a social justice perspective, but also from an economic perspective. So how do we create systems that share the burden of trauma across all different socioeconomic strata, right? As opposed to creating innovation that just targets the people who can pay for it, right? Because if we do that, then we'll constantly chase the top of the pyramid, constantly chasing the top of the pyramid, and we'll create little incremental innovations that are mainly, I hate to say it, like marketing problems, right? Whereas the real impact that we can have globally is to take innovations that have been around for decades and make them standard for everybody, make them accessible to everybody. So to get to that level, I don't have the answer, but that's the vision that we have, is that we can try to work towards that in small ways. And I think the only way that we can do that is through partnerships with people who have the experience in this field, but also local folks. Like when we think about the field of orthopedic innovation, costs have been significantly lowered, not by innovators coming from the United States or from Europe, but from folks coming from low and middle income countries, manufacturers in China, in India, and Turkey. These guys have, by necessity for their own populations, innovated to create something that's affordable. So how do we break down these borders and really start trying to solve the problem for everybody? It's a combination of manufacturing for extreme affordability, it's local manufacturing, it's regulatory issues, it's monitoring and evaluation to make sure that our interventions are actually doing the right thing. It's also education, right? It's bringing in more people from the education side. So yeah, I'm sorry I don't have like a clear, distinct answer for you on that one, a bit of a rambly one, but the reality is it's a tough nut to crack.
Thank you.
You've also spoken about decolonizing global surgery and the idea that the traditional model where institutions from high-income countries arrive with ready-made solutions often does more harm than actual good. What does a genuinely decolonized approach to global orthopedics look like in practice? And how do you approach this as someone coming from Harvard?
Yeah, I mean, gosh, perhaps I'm part of the problem. Right. And that's something that, no, I say seriously, I need to think about, right? Like me showing up with Harvard on my name tag, opens doors, deservedly or not deservedly. And I don't take that for granted. And I recognize that perhaps there is a tendency to bring solutions and pretend that they are the solution. And I've been working in global health since I was very young, and I've seen that in practice. I've seen folks show up with, oh, well, this is the way that things should be done. Well, let me tell you how it should be done. This is the solution. Why don't you just do this, right? And the good-natured response from a lot of colleagues is, oh, thank you so much, that's really great, and then things don't change, and then there's frustration and there's bitterness and complex power dynamics. It can be very complicated, very, very complicated. I think decolonizing global health, it's an interesting term because, to be perfectly frank, the concept of global health, or at least its practice, inherently is kind of colonial. It comes from a colonial history, right? To say, like, I'm here in America and I'm going to go to Malawi and make things better there, right? Missionaries and folks have been doing that since the 1700s, right? From European countries going and trying to make things better for the indigenous folks, right? We all know how much good that's done and how much bad that's done, right? We can never look at things only through one lens. So, I think that, back to what I was saying earlier, the most important thing is to just give voice to our local collaborators, that's the only way that I think we can ground ourselves in anything real and anything that attempts to decolonize something that comes from a colonial tradition. You know, I mean, like, we all have experiences having lived in a country built also from colonialism, right? I think that we can't undo history. We can live in it, and we have to come to terms with it and accept it, and do our best to use what's good and discard what's bad, right, and change it. And so I think, like, what I can do is I can recognize that the role I play coming from Harvard and representing the organizations I represent is to try to lend that power to our partners, to try to uplift, their experiences and perspectives in a way that they can tell their story to a wider audience. And perhaps when that story is brought to Boston, more people in my network here can benefit from learning their story. So it's really like I view myself as trying to be a catalyst, trying to be a megaphone to amplify the voices of others who are working in the field. And I think that I try to force myself to try to be humble in that way. That the power that, whatever power that comes with responsibility or role or pedigree and training can disappear and could be so easily have gone to someone other than me, right? So anyway, a little bit philosophical there, but I think that it's a really important question. How do we prevent ourselves from falling into the same tropes that created this system that has so much inequity already in it? How do we break that? It's really, really hard. It's really hard.
Yeah, thank you. And then for a trainee here in the U.S. Who would want to engage in global surgery ethically and meaningfully, what's the most important thing they need to understand before they even leave the country, in your opinion?
Well, I said humility earlier. I think that's very important. I think that the kind of misconception that a lot of trainees I've worked with will have is that going and being there and doing something is somehow more important than learning and reading and listening. I think the first step is to do that, right? So any student who wants to work with us and approaches me for a research project or an education project or whatever that may be, the first step is like, what have you read? Read everything that you can first, and I'm just giving my own experience just as an example, but what has worked for me is when I first went to Malawi back in 2016, I ended up in Malawi because when I was a fourth year medical student, I did a rotation actually in South Africa. And I worked in a rural health center there and became very interested in rural agrarian populations and how they get access to trauma care, right? Because it's common trauma. It's like a universal thing of reality in life. We will all experience it. Whether it's a life sentence, that's another matter, right? And so when I was working in that rural hospital, I became interested in for rural agrarian populations where they're by necessity cut off, by definition cut off from access because they're rural. They're also poor, right? So they can't afford it, right? If we can think of solutions for those folks, we can think of solutions that are scalable globally for everybody, right? Like a solution that makes care more accessible to like a rural mama living in a village is going to benefit you potentially if it makes care cheaper and better, right? That was my thought. And so I talked to a bunch of my mentors, read as many papers as I could, and they said, well, if this is what you're interested in, what you should do is you should go to Malawi. It's nearby, Southeast Africa, very rural agrarian population. And a lot of orthopedic surgeons, a small group of orthopedic surgeons, I should say, but a strong interest in trying to make the health system better. So go to Malawi. So I read every paper that I could find online about Malawi and wrote a whole bunch of ideas. I was like brimming with enthusiasm. Yeah, I'm going to go to Malawi. I want to work on all these research projects. These are all my ideas. And Leonard, I talked about Dr. Leonard Bonza earlier, met me at the airport. Kind enough to do that when I first arrived. Never met me before that day. And within a day, half the projects I realized were garbage, right? Poorly informed, poorly created, and just scratching them right off. And that came from listening, from just like talking to Leonard and just hearing what he had to say, right? And then slowly over time, the projects merged into something that was actually useful for Leonard and for Linda Chikoto, my other colleague there, and that's where the research collaboration began to grow, So that's what I would encourage anybody who's thinking about trying to do global health is start by learning and listening and reading. I've also worked with plenty of students who, for good reason, have this beautiful romantic idea of what it means to go and work in a low resource setting. They read like Mountains Beyond Mountains, the Paul Farmer story, and they think to themselves like, that's what I want. I want to like go to a rural hospital and work in this place and really help people. But the reality of that on a page in a book or in a movie, and the experience of going to a rural hospital in the dry season in Malawi and having 60 kids with horrible problems that you have no power to address. Those are two very different realities. And the latter can be extremely traumatizing. There are very few of us that have the fortitude to deal with that. But I tell you who do have that fortitude is people like Leonard Bonza, who actually do that every day, right? So tying yourself to someone like that who can guide you, right? And doing everything we can to support them. That's, I think, the vision, rather than pretending that we can like be Superman and go do it ourselves, right? So, yeah, I hope that's helpful.
Definitely. Yeah. Thank you.
Thank you. And as we've kind of gone over, you founded 2 organizations, developed novel medical devices, run a research program across multiple continents, and done it all while maintaining a full clinical practice here in Boston. For anyone in training who's interested in doing something similar, whether in global health or anything else, what does it actually take, and what do most people underestimate about the process?
Wow, good question. The way you put it makes it sound like, very exhausting, to be honest. And there have been moments where it's been very difficult, of course. I won't say that it hasn't been. But it's only been possible because of the people around me who supported me. That's one thing. My mom has a great expression. She says, life is a long affair. There's time in life to do everything, but not at the same time. Time and place for everything, right? Mm-hmm. So when I was in my residency, the focus was becoming a good surgeon. All right. When I was in my research fellowship, the priority was learning good research skills. All right. When I was in undergrad, my priority was learning the design process and engineering, right? So as you go through your training, there will be, of course, this yearning to reach the destination. But I think the journey is really important, and there are phases in everything. And when I think about the work that I do, I mean, like I really am very, very grateful for the opportunities that I've, been given by so many people who've supported me. And I sometimes pinch myself and think to myself, like, all of these different interests that I, as a trainee, didn't know how to combine. And many, many people told me you'd never be able to. They told me you'd never be able to combine these things. I've somehow found it possible to do so. Whether or not it goes for another year or more, I hope it will. But I think that the most important thing is persistence. Just like being doggedly stubborn about what you're trying to do, and like really believing in it, and having other people around you who can kind of like, feed into that delusional sense of self-importance, maybe. I don't know. Like at least support you and recognize the passion that you have. So my wife, my family, my mentors, like they've been the ones who've really helped me open the doors and also walk through them. And I will say that the one like very practical advice I will give you guys, and perhaps I don't give you guys because you're all here, is taking steps back from like a pathway that's trodden by many other people. Taking a step back and doing something that feels right for you is never the wrong answer. right? That's always a good decision. For me, every time that I've taken a step out of the medical school curriculum to go to a research year, taking a step out of residency to go do a postdoc fellowship, those have always been good experiences, always have helped me grow. And I owe so much of what I do today to those experiences. So take them if you have them. Yeah.
Thank you. That's awesome. And like you mentioned, it hasn't always been easy. Has there ever been a point where the scale of the problem felt overwhelming and where the gap between what exists and what's needed was so wide that it felt like hard to stay motivated?
Yes. Yes. Simple answer is yes. I think that all of us as orthopedic surgeons have a tendency of seeing a problem and liking to see it solved, right? Like when I go in to fix a fracture, broken at the beginning of the case, fixed at the end of the case. Satisfying. Feels so good, right? You walk out of the operating room, high-fiving, we did it, right? That's not the feeling you get from global health. There are incremental improvements, and those give you hope and motivation to continue. But I think you need to be honest with yourself that sometimes you move in the wrong direction. Sometimes things do go backwards rather than forwards. And I think you can't do global health with this idea that you're going to solve problems. You're going to make the world a better place in your lifetime. I think you have to go into it recognizing that you are trying to build a foundation that others, you guys, will build on, and this is a lifetime of work. And perhaps a generation, will go by before the fruits of it actually matter and change things. But then you look at the trajectory of global health, right? And it's been incredible. It's been incredible to see the transformation of, in terms of, human justice and health access. So I think there's a lot of hope. But if you tie your satisfaction to the small wins, the fracture fixed kind of mentality, then it's not the right field for you to go into because you will burn out. There will be this feeling of constantly pushing a boulder up a hill. And if you can't enjoy that, then not the right thing to do. Yeah.
Thank you. And just to kind of finish it off, what's the next step for HGOC and SONA? What are you trying to build over the next 5 to 10 years?
Thank you. Yeah, good question. Well, I think one thing I'm very proud of with HGOC and SONA is we are an organization of many, many talented individuals. And what we build is built by the vision of many, many people. So what I tell, Sion knows this, we really welcome people to use SONA and HGOC as a platform to see their vision come to life. And our educational conferences, like the translated subtitles and the multiple videos in multiple languages, these are visions that were executed by folks in your shoes, Sion, who saw this as something that would be really cool to do and did it. And we receive feedback also from our network as well, who guide us. So I will say that I don't know entirely what the future will bring, because I think the future depends on what people do with what we've created and where people take it. But I will say that our vision is to take our two devices and create a sustainable system whereby they can be accessible to more people. And SONA Global is a nonprofit. I want it to serve as a vehicle that connects a sustainable venture that is going to serve the needs of the poor and grounds it in that mission, and then fuel the research and development and education work here at Harvard and through SONA as the nonprofit that can train the surgeons and build the resources and innovations to make that happen. So it's really, we're imagining an ecosystem, and that ecosystem I think depends very heavily on the partnerships that we create. So in 10, maybe 20 years, could we imagine local manufacturing of devices, local centers for innovation where young, enthusiastic people like you, perhaps in Rwanda or Botswana, are coming forward and saying that they're interested in working on specific things, coming up with new ideas, right? More research funding to support the surgeons who want to build these programs and research collaborations and projects. That's the vision that we have. And my hope is that when the next time we go to, one of these big orthopedic, what's the big one for foot and ankle that you guys go to?
AOFAS.
AOFAS. Next time you go to AOFAS, instead of just a panel of folks from high income countries, let the panel include folks from low resource countries. And don't make it like a little side event that only the people who do global health go to. Integrate it in a way that the message of access is ubiquitous. Make it in a way that the voice of surgeons is part of the voice of foot and ankle surgery for all, right? I mean, that's what we're hoping for trauma. I want a panel talking about hip fracture care that includes my colleague from the Gambia, who's using the resources that he has available and showing the outcomes that he has had and giving tips and tricks that's relevant to the person in the audience who's sitting there from Burkina Faso, right? That's the vision that I think that from the academic side, we should be pushing for. So, yeah. Let's see if we get there.
Thank you so much. Dr. Agarwal-Harding, thank you so much for your time today. The work you're doing through HGOC and SONA is a reminder that orthopedics doesn't stop at the doors of the hospital, and that some of the most important problems in our field are the ones that are hardest to see from where we sit. Thank you so much for taking the time today.
Thank you. Really appreciate it, guys. Thanks for the time, yeah.